Thank you very much, everybody, to invite me to this exchange here. And as you know, I'm not the specialist in hepatitis, but I have, of course, lived through hepatitis, HIV, through the last many decades while working in Africa and Asia, and having also worked here. I worked here, I mean, the Corona Task Force is just an add-on. My main function now, after retirement from the Swiss Tropical and Public Health Institute as director, was to be now president of the Swiss Academies of Sciences. And it's a little bit in this function, and as president of the EXI, I would like to give you some insight in what you gave me as a topic. First of all, I must say that, I rather see myself not as the epidemiologists that are often cited. I'm rather more actually a public health person, but have my roots in basic cell biology and immunology. So I made this way, and it's also a way from the innovation to application, and also having been confronted in many situations with this translational process from science to policy. And this is actually a very important issue for us in the academies, because I must say that we have very often also as scientists made the mistakes that we actually don't only make scientific policy relevant statements, but we have the tendency to make policy prescriptions. And that is in Julia's presentation, this doesn't come out. The process to policy often fails when scientists make policy prescriptions. You see this also in Corona, when people behave as they would make policy prescriptions instead of just making policy relevant statements. I think that's a key issue in order to keep the science as science, but putting the science onto the transmission belt to policy and strategy in any situation. And in Switzerland, we have, as the Corona situation shows it, a little bit lost this capacity. And I have seen this with the topics in the academies of energy, agrogene technology, biodiversity, climate. Too many scientists want to make policy prescription instead of just doing their science. And I think the success that we have here, and we want to have here in the whole hepatitis combined with HIV, it's not the integration actually of the elimination of viral hepatitis and into the HIV elimination roadmap. No, it's a fortunate combination based on science that we try to drive forward. And the final remark is, I speak to you here in a way of trying to show the challenges we are ahead. I try to come very basic to the practical challenges we have in this working on the transmission belt between science and policy. And I would like to share now my screen with you, and I hope it works very well. And it should work. I hope so.
It does work. We can see it very well.
Then we are very happy. So we move on this issue. I would like to show you a little bit from science to public health action. Now, on the final word, my dear friends and Catherine, I'm not an expert. I'm just a person who has some expertise and experience, as many others of you all, and together we just make it work. It is one of the big stupidity in this policy process that some people are called experts and some are called politicians. Everybody has his or her own expertise and experience. We just bring it together because we sit in the same boat and want to move things. One should totally eliminate this stupidity of these experts, because we just bring in a common sense for public health and for many other issues, our our experience and expertise. I may be hard on this, but I think this would help a lot to get a better policy process. I would like to go a little bit from control to elimination, some frameworks and steps, and mainly the strategy in relation to the challenges we have. This was a wrong thing. That's the epidemiological data that Julia has said. It needs that. This does not show the whole epidemiological data. It's just a reminder that we actually have, be it for viral hepatitis, for HIV, we have a lot of sound epidemiological data. It's true what Julia said. They are very often fragmented and we have to bring them together. And I just chose one of the statistics for HIV to show how it changed, exposure changed over time. And we still always have a lot of unknown exposures, but it shows you what we went through. And the same is what we went through with hepatitis C. These are just symbols, these graphs. We don't discuss these graphs. Symbols for the fact what Julia said, sound epidemiological data we need, and this fact that actually these data, and that's the interesting thing, when I had the interesting contacts with Philip, Bettina, and we were actually discussing in EXI how, with also the interesting data, we should now, not we could, we should now move towards an elimination strategy. And it's fortunate that we found together, that's talking to each other, and that in order to move this issue. So let's go on. So here you see, and I start now with HIV, but I will also come back to viral hepatitis. That was the state before we actually had, the combination with viral hepatitis. And what, I don't go too much into detail, but that was the framework we worked on. We had actually here the structural prevention from our legal framework, our immigration dynamics, migration dynamics, the knowledge about the organizations, everything you need also for in order to capture the cultural factors, the psychological factors, and then of course also the bioepidemiological factors. And these were like building blocks. Don't concentrate too much on that, but the other part was here below, we had actually the flow, how prevention in the system goes from this, we knew about what was linked to preventive services and what not, how people were assessed and what happened. You don't have to look at these boxes, but you just see that this box is contrasted with the individual way of secondary prevention, what happens to a patient. And so we compiled these elements in our EXI work with the different dear colleagues that have actually built the building blocks. And this is not a model, this is just to show you how we built up the case for elimination. And then we looked at what is actually available from the campaign side, but also from the technical side, having condoms, of course, related to cultural issues, the PrEP, the pre-exposure prophylaxis, the testing that was established, and then finally, on the individual patient secondary prevention side, the availability of PEP, the post-exposure prophylaxis, and the ART that you know very well. So when you really look at this, this is not just a few colors and a few boxes, but it shows you when you assess each block, and this is we have done, this document is available for viral hepatitis together with HIV. It shows you there is a feasibility or even a must to move towards a thinking of elimination. At the same time, on the viral hepatitis side, one had developed, and that's why I take it, it's actually how you have established the continuum of viral hepatitis services and the whole retention cascade. This is coming from you. And when you also look at this in a society, and particularly in our Swiss society, you come to the conclusion that scientifically, but also given the health context you are in, it would work to really move towards elimination. That's why we actually moved together and developed this concept that I will now not present to you because you can see the details, but a few key issues that are important for the policy dialogue, or important in terms of what I said before, making policy relevant statements. So we got together and said, if we can combine, then, and if we lead this through, as you will see, we will not only have a major impact on viral hepatitis and HIV/AIDS, but we will also have a major impact on the other STIs, sexually transmitted infection. So without even really now wanting a program that includes everything, the spearheading with viral hepatitis and HIV will make a major impact on the sexually transmitted infection. So where do we end up? Actually, the question then was not so much to go in models, frameworks, and whatever people usually do. We started actually said we have enough sound epidemiological data. We know our system, but where our issue is actually how can we make clear that we are and also where we have to insist on the tools and approaches that we have the adequate one. That's why this picture, you know, this guy doesn't have the adequate tool to knock down this tree. And we had actually to ask critically, if we make a claim for elimination, do we have the correct tools? Not only the tools and technologies, do we also have the data flow, the way of doing surveillance? Can we collect minimally essential data in space and time? And do we have processes with well-defined roles and responsibilities, as well as ethics and legal frameworks that actually help us to really knock down the tree? So keep this picture in mind, and now let's move on. And we then actually said, if we look at that, we basically need 5 approaches and tool areas. That's much more detailed when you can later on look at that, and I'm sure people like Bettina can circulate it to those who want to see how this looks like, this roadmap to elimination. You have to have the preventive messages, clearly risk-based, and we have to insist on communication and not only on campaigns. Just to jump into these days, one of the things that don't go well in the corona situation is that we are actually too much campaigns and propaganda. You cannot just stick up red and blue posters. You must actually do communication. Risk-based communication is the same issue, and there we still have to do a lot. This is technical, but it is within a political framework. The means of prevention, I don't have to say more, but it is actually not only the technical tools, but it is actually also how you actually, which setting, the periphery of a health system, which setting the supervised rooms and centers and so on are equally important. So if you start thinking about what we need here, you actually see that the policy issues are manifold, interrelated, and reach a certain complexity. We have the testing here, which this is a more technical one, but also it is a way how we test. We have in HIV, we have the rapid diagnostic tests and the self-tests. In viral hepatitis, we have rapid diagnostic tests, and the self-tests are on the way, combined with HIV. So when you do this in a health system, and if you really want to promote this, is a policy issue also, not only just to throw tests in a vending machine, like a pregnancy test, but actually also how do you carry people who generate the results in the system, and what does a state do with that one, public health system with them, and up to the financial situation. You have the emergency prophylaxis as an area, and the treatment on care prophylaxis. You know all this, but this I needed to show these five elements of approaches to look at. Now, this strategy of eliminating HIV and viral hepatitis should cover the period from 2020 to 2030. And here we assume that we have an annual reduction in HIV of 30%. We hope that in viral hepatitis we reach 30% at the end of 2020, around that. At 2025 we have 60%, and we have 95% by 2030. The pillars is actually the essential response package in the frameworks that you have seen, and the delivery part with a very strong equity focus. Given the many population groups that are involved, partly neglected and discriminated, this equity issue as a pillar of becomes very important. And you feel already how here we have politically still to do a lot. And linked to equity is the financing for sustainability. Has to do with issues like the compulsory health insurance, has to do with issues like also no blacklist in this relation, and finally one pillar remains, that the innovation, not only for having, for instance, for viral hepatitis a home test, but we have actually also have to have innovation around the legal and policy hurdles. If you want to drive a strategy like that, you cannot just accept each legal and policy reason. You must explore what is the flexibility, or then the need to even change the legal framework. But actually this is a very important thing, that when you have a science-grounded strategy, in this case the elimination strategy, this one should really explore which other legal and policy hurdles we need to tackle. And the goals are, that's different from the pillars, the accountability. And it's important here to state, which again shows you that the policy level is not only Federal Office of Public Health and the Parliament, it is also the NGOs that care so well for the different target groups that are involved in HIV and viral hepatitis. We have the access issue, the key access for everybody, the integrated one, that we actually bring access of viral hepatitis and HIV together towards a concept of universal health coverage. The sustainability issue is a goal that we must not only build on participation, but we bring also the science and innovation together with the political support. You need also political support, not just for a public health action, but you need the political support for the innovation. And particularly the innovation, as I mentioned before, the innovation also at the policy and legal work, not only at the technical one. And finally, this is a conclusion, is that in any elimination strategy, we know this from many other disease situations, and particularly in the field of neglected diseases, neglected tropical diseases that have occupied me for about 40 decades. The key issue is to establish surveillance response. The key issue is to eliminate this nonsense of monitoring and evaluation, because that's hunter-gatherer operation to collect data. Surveillance response means the minimal essential data in space and time, that you see that something changes in a subgroup or in the whole population, and that you bring in the public health response. So you see 4 pillars and 4 goals. That brings us actually now to the political challenges. Here on the political challenges, some things come again. And I think these need to be now negotiated. That's our interesting, that's not a drag. That's nice to do this. It's actually the elimination challenge that we have in the policy level, that we actually have then what is born as a roadmap for viral hepatitis and HIV is brought into a national strategy for Federal Office on Public Health and the cantons and the NGOs involved. Not something that the Federal Office of Public Health does and the NGOs have to adapt. No, then we certainly will fail. And I think this is now what has started slowly, a little bit delayed because of the corona situation. And then comes actually the work, and each of these challenges have a different time scale. You cannot do everything at once. So the first one, the elimination one, you can start yesterday, and we have started. The next one is the accountability, actually among all players, all stakeholders, and that we actually include here, not just start first with the Swiss population, or start first with one stakeholder group, bring this together from asylum seekers. Okay, this one group, that's an example. That doesn't mean the others are excluded. Just for the slide to make it simpler, the compulsory health insurance issues, the no blacklist issue. This is something also where the process on this transmission belt from science to policy has started already. So you see, there are these different issues are at a different speed on this transmission belt. Then going up to the access issue, that is actually on the basis of the whole thing. The access to primary care, where GPs play a role. That's a totally other strategy. And just to make a few declarations in Bern, and a few things, it is really working here with the professional groups, working here very clearly cantonal and across cantonal, working here with the GDK, with the Conference of the Directors of Health. And then actually with the access is linked, of course, how free are these services, that we have here coherence. And I think this goes together, a systems approach. And finally, or nearly finally, the sustainability means that we are not just having a few declarations, but what we still need to do in order to actually come to this strategy, to the accountability issues and access issue, is that we have to make now an investment case. This sounds for some people very terrible, but through cost effectiveness and certainly cost benefit, where we actually go for service cost models, we can actually make the case how we can guarantee this access. And that's something, for instance, where I must tell you, this is an enormous force in this transmission belt to policy, but there we have not yet so far come. And the surveillance response is something which I already hinted at, that this is a key. This is actually, we have to develop for Switzerland. Switzerland still functions as a hunter-gatherer society with data. One just tries to collect whatever you can. And academics are the most terrible people because they always want to have an indicator more collected. And they go for maximally possible data. And there are endless nonsense discussion about these issues. What we want and what we need in all these situations, and not only viral hepatitis and HIV, we need surveillance response system. and we have to develop them. And so survey data collection as minimal essential data in space and time, and have the processes that we get this information quickly. Jumping to Corona, this is one of the big misery, that we don't get from the canton to the federal level in time, the data, the TTIQ, the testing and the tracing, isolation, quarantine is not working. It's working, but the processes are too slow. And actually it is not so much only on having an app, but it is actually we have the processes that we actually can do surveillance response. If you want to use PrEP or PEP in a good way, then you need to know in time where foci of transmission can be or were in order to intervene. So this means from bad means not bad, it means best available data, to med. This doesn't mean from bad to medicine, it means from best available data to minimal essential data. This is what we do, and these 5 issues that are important for the TIASILO have to go. Now I changed the title, that every stakeholder group has to be part of it, from the MSM to the drug users, over the prisoners and. So you see the challenges are substantial. The challenges are substantial for elimination, but they have a clear position on this transmission belt. Some things we have started, and some things we have to start now urgently, when we have all the capacity again to handle it despite the Corona situation. And then comes something which is very important more generally for this policy process. You see, many people see the problems like this man here. You have a huge problem to solve, and then you just wait there and look, and this could be a scientist who looks and sees how this moves and measures the millimeter that this block groove, and says, no, I don't understand yet, and I need more studies to understand before I can make suggestions for public health. Less academic, more humble and very pragmatic means going back to something which is a key in public health policy. That's what Sir Bradford Hill wrote when he worked on the relationship between smoking and lung cancer. When people said after his first case control studies, we don't believe you, you need to work more to show that this is, and then Sir Bradford Hill wrote for all of us that all scientific work is incomplete, but we cannot just say, wait a bit, we need more to understand. By the way, a student who writes, or even an experienced researcher who writes in the last sentence of his conclusion, this problem warrants more research, that is stupid, that doesn't help public health, because if you say it needs more research, you must at least say which research it needs more. But the more important point is here, you always know enough. You always know enough to already translate something into public health action, into policy. That's how we have to see also in this wonderful task now to go for viral hepatitis and HIV elimination. This is this principle that we should keep, and this keeps us turning, and this gives us the enthusiasm, passion, and the drive to move evidence-based. And we know the road to success.
Come to an end. We're kind of late.
Huh? Yes, I know. This is the last slide. That's the last slide.
Okay, great.
So you know that on the road to success, there is no shortcut. And I thank you very much, but you keep not this shortcut issue. You should just never give up. Thank you very much.